So what we do is we have only one diamond point that we use it for all over, and we don't even switch over between what instrument to use at the appropriate time. We don't have the instruments handy. We don't practice a forehand dentistry sometimes. So all this also will influence the quality of treatment that we give to the patient. Technical factors. Sir told this morning entire, I think number of times he told technician. Yes, dental technician plays a very important role in any type of processes. But when we tell processes, it's more than 50% that we don't communicate to the technician. That fault is also on our side. We fail to communicate the technical intricacies in each of the restoration. Okay. So what is, there is a big communication gap between the dental technician and the dentist. Or you hand over the work to the assistant or an intern working. So I'm not telling interns are bad. I'm telling that interns lack knowledge because of lack of experience, but we rely on them. Then the technician also gives a little faulty restoration which we fail to see, understand. So these are the factors we see. What are common problems? So length of the edentulous span. We get a patient like this. So we think it's very straightforward, right? But you have multiple things to take care. Okay. So the number of teeth missing, the size, the contour of the ridge here, okay, and what is challenge is the status of all these teeth. Okay, so the patient thinks, ஏன் டாக்டர் ஃபிக்ஸட் கொடுத்துட முடியாது, எத்தனை பல்லு இருக்குல்ல, இத்தனை நாள் நான் இந்த பல்ல தான் சாப்பிட்டுட்டு இருந்தேன். He will demand, even if it is a grade 3 mobility, the patient tells, I am chewing only with that teeth, why you want to remove it, right? So nobody makes extraction. So we have to think in terms of preservation. That is what the patient wants. I don't want to extract any teeth, do something. So we are in a position to convince the patient and also convince ourselves for a good treatment. So what is very challenging here? The length. Why? Because it is out of the inter-abutment axis. So when you see this canine is not in the inter-abutment axis, it goes out of the arch. So whenever load is applied, so whenever there's a prosthesis, you have to think about your biomechanics also, the amount of load that is transferred. You're opposing, what we usually miss in this is an opposing occlusion. What type of processes the patient is wearing, what is the condition of the abutment teeth here. Does the FPD can withstand the occlusal force? Okay, so are we going to take the number of abutments that we are going to include in this? Are we going to use only a lateral incisor and a third molar as an abutment? Just because of the cost constraint. But can we use it? We cannot use it. Can, but with a questionable prognosis. So all these things are very critical in planning the treatment. When you get a edentulous space like this, you call it as a pier abutment. Like you have a class 3 and multiple modification. The patient wants only a fixed partial denture. Now the most of the load will be on this teeth. If you have an RC treated premolar here, then it is a problem. Okay, so that will be the load that is going to take up here. And again, you really have to be concentrated on convincing the patient as well as educating the patient what is the prognosis of this treatment. Now canine missing. A very easy, straightforward case. Now what will you do about this? The most of us go for a 3-unit fixed partial denture, right? Most of us. But I would say that in implant supported processes will be a better option if canine is missing. Again, I would say that it is prosthetically, it is out of the inter-abutment axis. So whenever you take, so most of us when we talked about occlusion, morning also sir was insisting on, occlusal concepts. It's really difficult as a clinician, as an academician. The occlusion is something which is very unique to each patient, and the occlusal concepts, designing a prosthesis based on occlusal concepts is really, really important. So when you think about that, unlike your complete denture or a removal, any removal processes, you have to give a bilateral balance. There's no change in that. That is the concept. But any fixed partial denture or a full mouth rehabilitation case, there are two concepts generally that we follow. One is canine guided, okay, that we call as mutually. When our anterior are in contact, you try it for yourself, your posterior disoccludes. That is mutually protected. Whereas posterior in contact, the anterior will not contact. That is called mutually protected. Another thing is a group function. You can see most of the elderly patients will have a group function. So these are the major two concepts. So when you want to give a canine guided occlusion, preferably you don't include the canine in the fixed partial denture. You go for a implant supported process. If the patient is not willing so, then you have to tell them the reason. But the first choice is a implant supported processes. Then can we give a cantilever here? A very common thing in our practice, cantilever bridge for an anterior. But we don't advise it, or I would not personally advise anywhere you practice, anywhere in rural, don't go for a cantilever bridge. Okay. They tell, theoretically they tell lateral has only one contact, so it will not, no, definitely it will fail. So you have to go for a conventional fixed partial denture. So these are the common things that we note down in our clinical practice, we miss it. Now, abutment selection, if you get a clinical case like this, we take a radiograph, now whether to retain or extract. So what we should do? And we get a patient like this, already RC treated, the clinical crown height is very less. We want to extract or we want to retain it. Now why do you want to extract this? We don't want to extract. Patient doesn't like extraction. And clinically evaluate. Take an opinion from an endodontist or you yourself evaluate the X-ray. Is the tooth symptomatic first? Do you have any lesion here? Is the clinical crown height adequate to place a post? Okay. So can we use this as an abutment? Secondly, if you don't want to use this alone as an abutment, take an additional abutment or take an additional abutment here and then inform the patient that the prognosis will be bad, so I am taking another tooth as an abutment. Then again a challenge here is the mesially tilted molar. So you have a reduced space. So how are you going to manage this? All this should be planned before you give an FPD. In between, if you go and tell the patient, I tried doing it, but I'm not able to do it, so you might have to go for an RCT. Again, you are going to be charged for another 3,500, right? So this is primarily because we don't make a radiograph or don't evaluate clinically and don't plan for a treatment. So 3-unit fixed partial denture is always not a straightforward case. So kindly evaluate every time you do an FPD, clinically evaluate, radiographically evaluate, ask the patient history because recently, even last we said, every day we face challenges, right? The patient, I was not told that the patient underwent radiation therapy. So this is, every RCT was going on, adding on. The patient had a lot of emotional pain and pain as such. So this will generally irritate the patient also. So all this happened because the first appointment was not properly planned, the history. Again, if it is asymptomatic, you can retain it. So you need not extract it. So as much as possible, prevent extraction. Even in a class 2 mobile abutment, you see canine class 2 mobility, whether to go for extraction, whether to retain it. But one thing you can try with the crown root ratio. Once you do an intentional root canal treatment and adjust your crown root ratio, you can still give an FPD with a class 2 mobility also. So you can see after giving a provisional restoration for 1 week, the mobility would have gradually reduced. One thing is because of the splinting effect of your provisional. Another thing is you can depend upon your crown root ratio when you can reduce more when you do an intentional root canal treatment. So these are the ways to actually wait for a period of provisionalization, examine the abutments, and still without extraction you can promise the patient a fixed partial denture. So don't extract when you always have a class 2 mobility in a lateral incisor also. You can still go for a fixed partial denture using that abutment. Multiple preparations. What is the challenge here? We think it is okay, multiple crowns. Okay, it's a good month. This month is going to be very fruitful for us. Yes, it is going to be fruitful only if we are able to plan our preparations. Now, what is the challenge is angulation. Okay, so everybody is comfortable with a single unit casting because fitting is very easy for us, right? But don't prefer that until you have a necessity with the sharp clinical grounds or something. Don't there will be a lot of casting errors one. And if you have a problem in one teeth, you might have to remove the entire bridge, which will cost more for you, more for the patient. And again is preparation. Preparation is a skill here. It seems to very beautiful, no? Very, very well retracted everything. But to give an angulation and prepare, this is also a skill. So every tooth, especially canine here, angulation is a challenge. Next, cementation. So for the ease of cementation, we ask as a single unit. But did you imagine that how will the patient be able to clean the processes? Mechanical cleaning every phenomenon without any interdental, self-cleansing mechanism. How the patient floss first? How will the gingival health be maintained for the bridge? So multiple preparations always prefer a single crown, where a challenge in a single crown cementation is a challenge, and also angulation of preparation. And definitely you have to retract. Use a gingival retraction cord and you have to do it. Next, very common thing that we notice in our clinical practice is a short clinical crown. Every day we notice. Primarily because the patient doesn't replace the tooth, or the endodontist. I've seen many of the endodontists, like they prepare, their root canal has been done, but the crown placement will be delayed. The patient will forget because the pain is gone. Nobody is going to bother. So crown must have been 5,000, or they would have postponed the treatment really. So what happens is, sometimes the upper teeth supra a flat preparation they would have done, because to prevent pain post RCT, because the patient shouldn't have a post-operative or post-endodontic treatment pain, there will be a flat occlusal surface. Supraeruption will be there, and in that case the clinical crown height is also less. So it's quite difficult to manage in a situation like this also, even more lesser than this. So in those situations, you cannot do a crown lengthening. In those situations, you can attempt a crown lengthening here. You have enough gingival without disturbing your biological width and attached gingiva. You can achieve one amount of crown lengthening, and then you can modify the provisional, etc. But in a situations like this, even in a molar, in a distal, well, you cannot go for crown lengthening. So definitely you have to modify the preparation. So how do you modify the preparation is basically, you can prepare a class 1 cavity into the crown itself. Like, not like exactly endocrowns, but you can have a class 1 like an inlay cavity, then that can be used as a way to retain such crowns, where crown lengthening is not at all possible. Another very common challenge here is your mesial inclination, okay, of the molar. Very common, mesially inclined molars. So what we usually miss clinically is we don't notice, but when we take a radiograph, it is beautifully shown that the mesial incline. What happens is, when the patient loses the teeth, there is a movement that is happening. The movement in all flow directions. The maxillary molar will come down, supraerupt. The lower molar is mesially tilt. Since the maxillary molar supraerupts, what will happen? If you have an adjacent teeth, you will have a decay in this, because there is a gap due to the tooth movement. Obviously, in 3 planes the movement will happen, and there will be a decay on the proximal surface. So most common challenge is this. What is the challenge is, you don't have enough pontic space here. And sometimes there will be in this situation, there is a supraeruption, seems to be like that. And there is a tooth movement that has happened here, that is causing a discrepancy in occlusion also. So managing these kind of cases are also difficult. In this case, either it will be a better choice to do an intentional root canal and then create some space for your pontic, rather than keeping a very small pontic that will not serve the purpose. Okay. If it is going to be a maxillary that is supraerupting, you can also try orthodontic intrusion. That I think orthodontists will know better. So if there is a possibility of intrusion, if they give, then you can try, and the patient is willing to wait for some time. So with all these things, we have to plan the treatment. So what usually we miss is X-ray, root stems inside the edentulous area. Okay, very often we can miss it. Okay, so that is possibility is there. So when a patient comes like this, okay, patient 30-year-old patient comes after 4 years of orthodontic treatment. Okay, sorry for the picture, but this is what I got. So 4 years of orthodontic treatment, they came, and this is the clinical picture. He came for like, how can I mask my space? So what can you do? Yes, I can mask, but immediately on the same appointment, we cannot do a preparation. So once you prepare, when you are not able to achieve your midline, your arch symmetry, your tooth size, and when you are not going to do a proper space management, then again you end up in a problem. So what is very important in this is your pre-treatment planning. So you make an impression, give it to the technician. You can do a digital mock-up beautifully and show the patient this is what is going to be, this is what you look, and this is the mock wax up of what your future processes will be, and are you okay with this? So this is our pre-treatment planning, that you can educate your patient, visualize what is imagine what is the post-treatment outcome, and then plan. If you are not doing it, most of the problems that we face is tooth size discrepancy, and we will not be able to match the midline, okay, and the patient also will be little unhappy about the outcome. So starting with all these challenges now, what is on our side? So the most common thing that we ignore is your diamond points, the burrs that we tell, usually in a common term that we call it as burrs. Okay, so those what we use are called diamond points. So we rarely look up the specifications on a burr. Do we? I don't think. So even if it's burnout or black, we try pressing the hand footrest so that we can do some preparation on it. That's why that's what usually when you don't have the correct armamentarium. Instead, you can have a checklist like how to discard a burr, okay, and how to maintain a aorta handpiece, which torque you have to use. All these things, you can educate your clinical assistant to change your diamond points very frequently, like how many patients, depending upon how many patients or how many preparations you do. So what are these points here? How does this play a role, this color coding, like how we have a color coding on reamers and files. We do have a color coding. What does it denote? It denotes the grid size. Do we have all the grid size in the clinic? I think not always. That's the answer, not always available. So what is important? Standard size that we choose, the blue ring, okay, and extra fine is that yellow band. And we also can use this, okay, we do use this, and fine is your red, and super coarse black, we rarely use this. So standard, what we use is the blue, okay, that is what the beginners also can use. People who are experienced can try this course, because sometimes in aged patients, when there is more of reparative dentin formed, and when even the crown preparation becomes very difficult, in that situations, you can try this. You have something called 63C in this. It is a very short sham burr. Number is 63C. TF. That as a viscose grid you can get it. That is very useful for your crown preparation. So what is important is all these numbers. Sometimes we want to explore means, I would say this number basically is the diameter of this burr. That is what it is. TF means tapered flat. TF means tapered flat. TR means tapered round. This denotes this. This is flat, and if it is TR means it will be round. Okay. Basically it denotes the shape of the burr. So these are the burr specifications that we use. I'll tell you what surface. So other types of burr that we use is tungsten carbide burr. Usually you don't use tungsten carbide. Tungsten carbide, whenever you want to move a crown, a faulty crown, you can try with the tungsten carbide burr. It will be like a short straight fissure burr. You can get from the dental marketing person. Tungsten carbide cuts efficiently, especially if you want to cut a zirconia crown, that is very efficient in cutting. Otherwise, for tooth preparation, you can use a diamond burr. So these are the common list of crown prep burrs that we would advise. Everybody would have used this, but one thing is we don't use it in a proper sequence, that we should admit. Okay, everybody, including me. So we don't use it in a proper sequence. So for depth orientation, depending upon the tooth position, okay, that is very important. So where your tooth lies, whether it's an anterior or a posterior teeth, whether it's a premolar or a molar, whether it's a third molar or it's a first molar, all these are very important primarily because the amount of mouth opening and your access to the tooth is very difficult. If it's going to be a third molar, it's again difficult. If it's going to be an upper third molar, again maxillary, it's difficult. So you have to again mind map. So you have to get into that and think, what do I need for this patient? You know, the crown height is going to be little, the mouth opening is restricted for the patient, what type of handpiece I am going to use, what is the shank height that I am going to use, what is the grid size I am going to use, because I shouldn't engage the cheek or the tongue and injure the while preparation. So all these are not easy always as we think. Every day, day in and out, we are facing it. Mouth opening restricted. Patient has a very less pain threshold. Okay, aged patients. Okay, so all these things, distal wall, all are challenges. So selecting the armamentarium or the burrs itself is a challenge for us. This we could. So all this are most common that we have it in a clinic. Okay, so these we use it. This rugby burr we use for occlusal reduction. Finishing burr we usually omit the superfine. Actually, it's very essential to round and all our line angles and point angles. All this we read in book. But clinically, those are very important. How to round and the line angle and point angle. As and when we practice, we know all the importance of it. So this dimension, this taper dimension, why this is wider here, why this is narrow here, does it influence the tooth preparation? Yes. So always we talk about this two plane preparation, right? Two planar preparation. We don't talk about the straight preparation. Okay. So that is more of biomechanics here, the path of insertion. So we don't, I'll show in subsequent slides, we don't need to do a flat preparation. We always should follow a planar surface. The exact morphology should be maintained. We are only reducing the tooth height. You don't change the morphology of the tooth. So a burr dimension influences the plane of preparation, how you do a correct planar preparation. So that is very important. So it is wider as towards the shank and the tip it becomes the narrower. So enabling a better inclination of the handpiece like this, and while you go to the cervical, basic anatomy, if you prepare more, you will be more close to the bulb. So when you do a less preparation with this tapered round, there will be more preparation towards this surface, and thereby the two plane reduction will be maintained. So inclination of the handpiece and inclination of the diamond point is also important. So these are the various surfaces wherein you can use various types of burrs. So this is along the axial walls and a long thin needle. This is very essential in your practice. You have to have two types. One is long thin needle, one is short thin needle. You know, long thin, you do it in your anterior. Short thin, your posteriors. Because if you use a long thin in the posterior, suddenly if the patient closes the mouth, the handpiece gets locked. That usually happens. So that is there. And you have something called this this one is very useful in your occlusal reduction, especially premolars, and you can have this also. This is one good burr for the occlusal reduction. One thing is, this can deepen your occlusal, the central fossa. So that is very important in a crown preparation. So deepening that part, I'll tell you why. And this is a special burr. This is a tissue protection burr. What is very special about this? It doesn't have any diamond points all over this. It's a long shank. Only the end has a cutting surface. So you can actually refine the gingival surface with this without even damaging your gingival margins or the other axial walls of the preparation. So this is commonly used diamond points for your crown preparation. So what I told, what we usually do when the patient comes as an emergency, other patient is waiting there. So what we do is a flat preparation. Okay. So this is the molar, nice well-formed molar. Forget about untreated surface. Forget about untreated tooth. But when a patient comes with a correct occlusal form, okay. So we advise, or it is not good to have a flat preparation. So this is not what we should do. But we always do because lack of time, probably lack of proper armamentarium, and the cement is going to take care of the crown. Okay, it's not so actually. The cement cannot take care of the crown. It is we and the technician should take care of the crown. So what we do? We are in a hurry. We cannot use a long thin or short thin. What happens? The proximal ditching. Again we think automatically like in complete this also the tooth will move and get adapt. But what we actually miss it is the proximal contacts and contours. Every now and then we get patients in our clinic every day. I think we can see very common problem enna சாப்பாடு மாட்டுது. I'm not able to crown place பண்ணி ஒரு வருஷம் ஆச்சு, but still or after 6 months நல்லா இருந்துச்சு, 6 months அப்புறம் I am having this problem. Okay, food infection. So probably the contact and the contours were ignored there. The proximal contact. How often we check the proximal contact in cementation? Do we? Good. The first track. So we actually there is a very important step. While your cementation and in your even when your technician gives the crown, even before the cementation, first thing that we have to check is the proximal contact. So I don't think most of the technicians nowadays they are doing it, but most of them don't do it like that. So establishing a proximal contact for them is a challenge, and then we cement it because the crown looks very beautiful and the occlusion is good, but there is a proximal contact. You can check it with a floss. If that is going to be a problem, then it's a real headache for us. Again, the patient will be coming. So this is a video just to show for beginners. I think every day our friends are doing preparations, but we shouldn't miss out critical points in this. I think though with the experience, we often miss some critical points that actually gives a big difference. So what I want to tell in this is how the handpiece is, how to hold a handpiece first, how to position your diamond point towards the occlusal surface. So when you position it appropriately, the depth, here there is a depth orientation. I still follow this. Many of us would not admit for this, but I am comfortable in this way somehow. So if it is a properly formed, the teeth is good, then we can proceed. So this is the palatal reduction, just to show it is painted. Okay, the rest of the surfaces should be prepared like this. So when you hold the handpiece like this, I know it's not going to be very easy in a patient. It's a diaphragmatic model, so it's very easy. But to visualize, we have taken in this. In a patient, there will be a lot of hindrance, a lot of challenge. The first challenge would be retracting the tongue there. Okay, and mouth opening, obviously. Other thing is visibility, accessibility, how to hold the mouth mirror first, how to look at with the indirect vision. So many of us don't like visualizing with indirect vision. Right from our UG days, we don't actually practice it, but that is very, very essential in any crown preparation.